Good afternoon, everybody, and welcome to NARA's presentation of PT First, Models of Care Through Partnerships in an Integrated Health System. I'm going to go over just a few of our general housekeeping before we jump into our presentation with Stephen. We are recording this webinar. It will be available within 72 hours on the NARA website. If you go to NARAnet.org, it's NARANET.org. And then you go to resources and navigate to the quick links page. That is where you will find the handout for today's webinar. In 72 hours, you will also be able to find the recording there. We will send out an email reminder to you letting know that it is available. If you wish to ask questions of our speaker, please put them in the Q&A box. The Q&A box is listed at the bottom of your screen. If you have technical questions, you can put those in the chat. I will now introduce our speaker, Stephen Moffitt. Stephen is the Rehab Operations Director at Intermountain Health, specializing in orthopedics. With a Doctor of Physical Therapy degree from Regis University, Stephen is an orthopedic clinical specialist and a fellow of the American Academy of Orthopedic Manual Physical Therapists. He is dedicated to facilitating yearly and affordable care for musculoskeletal conditions and enhancing the quality of care through the integration of best practices across a large healthcare organization. Stephen advocates for the use of technology, partnerships, and virtual care to improve accessibility to and affordability of rehabilitation services. I will now turn this webinar over to Stephen. Stephen?
Thank you, Christy, and good afternoon, everyone. Thank you for joining today's webinar. Like Christy said, my name is Stephen Moffitt. I'm excited to share how Rehab Services is partnering with our health system at Intermountain Health to provide some PT First models and give you some examples. To start off, a little bit about myself by way of introduction. I live in Bountiful, Utah with my wife and as many of our 5 kids that show up on a given day. Our last 2 children that I can still claim on our taxes as one's a junior in high school and our other's a 10-year-old, my 10-year-old son who tries to keep us young as possible. Our home is located just a short drive north of Salt Lake City, where Intermountain is headquartered. I grew up in Utah and spent a couple years in Denver, Colorado for PT school and worked my first physical therapy job in Prescott Valley, Arizona, before moving back to the Salt Lake Valley to work for Intermountain just a little over 21 years ago. And I love living in the Intermountain West and spend as much time as I can outside. My 3 favorite activities to do with my family include skiing and hiking and whitewater rafting, which all are in abundance here in the Intermountain West. And so my background is actually on the Green River, where we spent 5 days floating some rapids and just having a great time. So love being in Utah, love being in the Intermountain West, and it's just a great place to live. So a little bit about Intermountain Healthcare for those of you that don't know. We are a large integrated health system that spans southern Idaho, Utah, Nevada, Colorado, and Montana. Our outpatient rehabilitation services include clinic-based services, hospital outpatient departments, and some embedded clinicians in a few locations. We have employed clinicians, physicians, and aligned physician partners with over 60,000 employees across the system. And our outpatient rehab departments include 64 outpatient clinic departments, 10 hospital-based departments, and then we'll talk about some embedded opportunities that we have across our system as well today. But to start off, I'd like to talk about why PT First models of care are important beyond just increasing therapist autonomy and direct access, and really focus on how PT First models of care can help our health systems and communities in the future. It's well known, the concern regarding current and projected physician shortages across the nation. A few of the factors that really play a role in this include the aging U.S. population, Physician retirement is becoming an issue with, I think a recent stat I read was that 20% of physicians are aged 65 or older currently. So that's a considerable concern as this bulk of physicians will soon be retiring. Burnout and workload concerns are an issue, especially since the COVID pandemic brought some of these things to light. And the time to train and educate new physicians to replace those retirings take considerable resources and effort. And then we also know about some geographic challenges, especially in our rural areas, that limit access to care because of the nature of those communities. And there are many health systems looking for ways to address this shortage and looking toward the future. I saw this article not too long ago about Sentara Health, which is an example of how this health system is using APPs to increase primary care capacity by over 70% without increasing physician providers. And so why is this kind of a model so attractive for physicians? It's really because of the improved access to care, enhancing patient care, cost effectiveness, because it's cheaper to hire an APP than it is to hire another physician, and it reduces physician burnout. But two other things that you can read about as well, which is very well known, is that physicians are able in this model to maintain control of clinical decision and supervision through APPs as they act as extenders to their practice, and also they can have increase in revenue without increasing costs. So the prevalence of musculoskeletal conditions or MSK conditions that can be managed by physical therapy and other rehab providers is very well documented also. The Lancet in 2020 published an article demonstrating that 1 in 3 individuals have health conditions that require some form of rehabilitative services. And then a Swedish study from 2016 demonstrated and investigated patients that were simply seeking primary care clinics and found that MSK conditions for which care was sought actually accounted for at least 60% of these cases. So it's very well known that MSK conditions is a huge part of what we see in primary care and a large part about what patients are seeking care for across the continuum of care. There's a study published in JAMA in 2020 that outlined the healthcare spending for the top health conditions in the US. Of these 8 top conditions, you could argue that physical therapists play not only a vital role, but actually a primary care role in the management of 5 of these conditions. So it's very evident the role that rehab providers can and do play in primary care settings. And so what is some of the evidence for PT First initiatives? Well, first, research shows that when patients see a physical therapist as the first line caregiver for these musculoskeletal conditions, they experience faster recovery, lower overall healthcare costs, and it can reduce the need for expensive things like imaging, medication, and surgeries. Patient outcomes are improved by integrating PT into primary care, which leads to quicker access to the care and also shows improved outcomes because of that early access to care. Physical therapists can play a part in the healthcare system by reducing workload on primary care providers and physicians by offering the specialized care, freeing up time for those physicians to actually treat the patients that they're specialized to treat, and can reduce some of the need for them to triage and then screen and refer patients. We also know that research shows that patients who see PT as a first point of contact have overall lower healthcare costs, and PTs can reduce the need for unnecessary imaging, medications, et cetera, like I said earlier. And finally, improved overall health outcomes, which are included as part of proactive care by providing prevention of future injuries and education through the rehabilitative process. Recently, in the state of Utah, our Utah APTA chapter has been successful in promoting physical therapy as a primary care in legislative process. Just Monday, I received this email from our APTA Utah board stating that the House and Business Labor Committee unanimously approved moving this bill forward, which would allow then our physical therapists to be recognized as a as a primary care provider in the state of Utah. Now, while this is great news, we must recognize that legal designation doesn't always necessarily change health plan policies. Health plans must also change and adopt the designation of primary care for PTs for rehab providers to see the benefits of decreased copays, expanding ease of access, and other services such as order imaging. So even though we're making some great strides in these areas in multiple states, there's still a lot of work to do when it comes to making this a reality. But today I'd like to really focus on three PT First initiatives, or what I like to call upstream PT initiatives at Intermountain Health. We have three things specifically that we're working on. One's the spine care navigation, the second's Connect Care physical therapy, and the third is clinical integration that I'll speak to. And at the end of this presentation, I'd really like to open this up for questions and discussion because I'd like to learn from all of you that are on this call as well, recognizing that there's a lot of great things going on across the country that we can learn from each other. And so hopefully this will be a forum that we can really work together and learn from each other at the end of this presentation today. So first, the first thing I'd like to discuss is our spine care navigation. It's a physician-led initiative with the intent to reduce the cost of care for patients with back and neck symptoms. Physical therapy and Intermountain Health has been promoting early access to therapy services for decades within our organization through demonstrating of effective outcomes and cost-effective alternatives to expensive procedures. And because of these efforts by our visionary rehab leadership over these many years, and in partnership with our neurosciences clinical program to reduce the cost of care for these patients, the Spine Navigation Project was launched as not a rehab-specific initiative, but a system-led initiative. And Intermountain's vision is to provide early access to low cost and high value care with the right provider for the patients suffering from low back and neck pain symptoms. It's driven really by the need to make healthcare affordable for our community and sustainable and simple for our patients and the community in which we live. Now, this kind of initiative is not new. Many organizations have tried with varying levels of success in developing similar pathways. Our organizations learned a lot from these fantastic and pioneering organizations, and we hope to build upon what they've learned and the challenges they have faced and try to overcome some of the challenges that we face through their examples as well. We believe that our organization is in an excellent position to successfully develop this program due to the shift in momentum from a fee-for-service environment to a value-based care, and our organization's aggressive movement toward our at-risk contracts, which results in over 50% of our current enrollees through our Select Health product, which is our Intermountain's sponsored health plan. They are now, like I said, 50% of these enrollees are now in the at-risk models of care. In essence, we want to develop the most simple and easy path possible for patients to receive the care they need at the right place at the right time without delays in care, and without navigating themselves a complicated healthcare system and without receiving multiple referrals and unnecessary care. We also want to provide a simple way for all entry points, including primary care, urgent care, and emergency care physicians to get patients easily and timely to the right care at the right time. To make this happen, a committee of Intermountain physicians from neurosciences, leaders from physician and rehabilitation services, and our enterprise continuous improvement team got together and designated a process to establish best practices from the literature. These best practices include early screening for red flags, avoiding subspecialty care where unnecessary opioids and imaging actually drive up the cost of care, and early referral to physical therapy. Now, this slide may look a little complicated, so I want to walk through it a little bit. This slide really outlines the multiple entry points here at the top of how patients can access spine care at Intermountain Health and how we intend to navigate patients to appropriate care quickly. We had to answer the questions of how we can capture these patients in a controlled manner to screen and navigate them to the right provider quickly and effectively measuring that data to demonstrate success. Also, the team didn't feel like the community was ready to self-select where to go based upon the number of patients currently presenting to the emergency or urgent care settings for back pain. So we determined that the best way to capture, navigate, and measure patients entering the system for low back pain would be to use urgent care, emergency room, and primary care settings as our entry point. Using these points, it would allow the team to collect accurate data and then measure any downstream cost savings from the navigation component. So physicians in these three settings, urgent care, primary care, and emergency room, they would be able to send patient information to our nurse navigator, who would then triage patients, provide red flag screening, and provide access to PT, interventional medicine, or surgery as necessary, with the goal being 24 to 48 hour access to each of these services where appropriate. And so you can see, the triage would be PT here. We could get them to the interventional spine where necessary and hopefully avoiding surgery where possible, but getting physician offices the right patient that needs to be in the clinic instead of having interventional spine and surgeons filling their clinics up with patients that really should be in PT and avoiding that referral process altogether from the surgeons and physicians. And so what we wanted to do is limit our pool of patients to one geography. So we limited this to the Salt Lake Valley, where we currently have 4 hospitals and numerous primary care and urgent care facilities. This initiative started in January of 2023, and since inception, we've seen an average of 24% of patients presented to the ED with spine conditions being sent to navigation, with 18% of patients with spine conditions being navigated from the urgent care and 3% from primary care. This slide presents some of the data that we're collecting across the system on the rate of opioid prescription imaging and spine surgery. You can see with each of these settings, emergency room being in the blue, primary care orange, and urgent care red, the percentage of patients that come in with a spine condition to any of these 3 settings and the rates at which they're receiving these three interventions. Now, since the spine care pathway was initiated, we haven't seen a dramatic decrease in opioid or imaging ordering from any of these 3 settings. There's been a downward trend in those areas, but where we've seen the most improvement is the percent of patients that come in and receive spine surgery within 24 months. We've seen about a third, the cases decreased by about a third based upon what it was before the spine care pathway navigation occurred. This is another busy slide, but it's a dashboard of our patients that are navigated into the spine care pathway program. And you can see the volume of patients, the spine referral pathways, the middle tile in the second row shows the majority of these patients, or 82% of them entering navigation, are referred to PT, with only 1% of patients that are navigated to PT refusing that care. The emergency department and urgent care teams are the most likely to use navigation, while primary care tends to lag a little bit behind in the navigation process. Physician support from the surgeons, like I said, and the medical providers such as physical medicine are very supportive of this because they're actually seeing more patients that belong in their clinic and fewer patients that really truly should be seen in therapy. And then for those patients entering therapy, if there is a need for referral into medical services, the patient is then contacted again by the navigator, and the connection is made back to those medical providers where necessary, significantly improving the time it takes to get into those medical teams. So this shows a slide. This slide's a demonstration of back in January of 2023, where I circled the slide here. You can see the percent of encounters of patients that have low back pain or neck pain, and what percent of those patients that come into our clinics in our physician clinics with low back or neck pain, what percent of those patients actually are scheduled with PT within 6 weeks? And you can see from January on, when we implemented this plan, the uptick in the percent of patients that are being referred to therapy because of navigation. We haven't seen as much of an uptick that we'd like to see in our primary care referrals to the navigation team, but part of that may be related to our primary care physicians are already referred directly to PT, so they may not see the importance of using navigation to get those patients to PT. Where we find some interesting data is the percent as we look at the patients that are navigated versus not navigated. So the top section here shows that patients who are navigated from primary care, urgent care, ED, over almost about average, about 50% of those patients get an encounter with PT within 6 weeks. But those patients that enter the system through primary care, urgent care, and ED that aren't navigated, a significantly lower percent of those patients are ever getting into PT within 6 weeks. So this shows the importance of navigation and the improvement in referral rates, but also the ease of access for these patients once they're navigated through this process. This shows how long it takes to get into therapy services. Patients in Salt Lake Valley who require access across the system since January of 2022 take an average of 2 to 3 weeks to get into therapy. However, that time's improved, you can see, since navigation started in all 3 areas. Again, with the reasoning for we think primary care doesn't see that significant drop that we saw in ED and urgent care is because they don't use our navigation as much as the ED and urgent cares are. So you can see this is a median number of days from the encounter, which is when the patient hits the medical practice of primary care, ED, or urgent care. And you can see when they're navigated, how much quicker how much quicker the patient is getting into therapy than if they're going through the standard process of just getting a referral from the physician and trying to navigate without the help of our nurse navigator. And so we can see that our urgent care and ED patients are getting into therapy very, very quickly, where again, primary care, they don't refer as much to the navigation, so they're still having challenges. But even with those that do refer, we see an improvement with those primary care patients getting in. And we've asked the question a little bit about, why primary care is still taking longer than urgent care and ED when they're navigated. And we think part of the issue maybe is the patients that see urgent care ED physicians are typically more acute, and so they're more motivated to get in quickly. So when we offer them a visit that may not work within their schedule, they're more likely to take that, whereas primary care patients may not be quite as acute, and so they're willing to wait a little bit longer to find an appointment that matches their schedule more effectively to get in for those convenient times. In our Intermountain, we measure outcomes very aggressively through our rehab outcomes management system, and we measure failure to progress, which is based on a 30% improvement in patient-reported outcome measures over the past year. If you look at our outcomes for those patients in the Salt Lake Valley with low back pain and compare it to our system, we do see a significant improvement in outcomes compared to those that are not in our Salt Lake Valley. And we like to think that this is a result of partially the navigation process because they're getting earlier access to that care. Therefore, we're getting better outcomes from getting earlier access to PT. But that's one of our drivers we feel that results in this clinical outcome improvement. In summary, for the spine care pathway, we have a great deal more work to do in improving spine care at Intermountain. And our pilot demonstrates that we are moving in the right direction to provide early access to these PT services and to reduce unnecessary care. The goal is to continue to be early, is to continue to get early access to PT services where appropriate. And our next steps are really to demonstrate cost savings through improving access and reducing need for additional procedures and surgeries. One of the challenges at demonstrating cost effectiveness is that patients are being navigated from expensive care sites, such as the emergency room and ED visits. So by the time they hit PT and they're getting the appropriate care, they've already expended quite a bit of cost in these urgent care and emergency room visits. So some of the cost savings may be blunted, that if we could get further upstream and have that entry point be navigation by itself, we could potentially see even more cost savings by having patients enter this pathway upstream and getting our downstream cost savings down. So that's what we're hoping to achieve in the future as we get momentum in this process. Now, another initiative that I'd like to address today is called Connect Care Physical Therapy. Connect Care is our virtual urgent care. It's a service that has been in operation across the system for many, many years and has been very successful in getting easy virtual care to our community. Connect Care, we approached Connect Care from the rehab standpoint to figure out how we could embed a therapist within the Connect Care service for patients that were potentially seeking virtual urgent care for MSK services without needing a referral to an in-person clinic. Because of this partnership, Connect Care Physical Therapy was born. However, we faced a number of challenges in building this process. First, patients entering Connect Care to see a physician were paying $69 per visit or having the cost fully covered as part of their current health plan. Physical therapy services were more expensive than $69 per visit and were not covered by their health plans. So it was a dissatisfier or reduced the likelihood of patients wanting to utilize this service if the cost was so much more than a typical Connect Care visit. So we were concerned that they would just opt out of that option up front. So to address this, we partnered with our health plan and our medical group where Connect Care physicians and APPs were providing the care and got approval to bill and provide these services through the Connect Care NPI and service line using the physician's E&M code that the Connect Care services were being provided through, so that our Connect Care physical therapy team was being billed for the same way that a Connect Care visit was and had the same benefits and was not counting toward our out-of-pocket, our annual physical therapy charges for the year. With that being put into place, we were able to open up our Connect Care physical therapy with our goal to provide that on-demand consult with the PT and educational resources for patients seeking MSK care. We wanted to reduce the downstream costs by avoiding further care, especially opioids, emergency room visits, or imaging, and wanted to make sure that if there was a need for further services, the patients could be referred for an in-person visit or further care outside of the Connect Care service line. This is some of the data we've been collecting for Connect Care PT. Since inception in 2023, we've seen 156 patients for multiple diagnoses and have been quite successful, we feel, in decreasing some of the downstream costs. You can see the number 156 doesn't seem like a large number, and we're a little disappointed in that outcome. We thought there would be a greater need and desire for patients to use this service. However, because of the inability for us to staff a full-time clinician, not knowing what the volumes would be for this service, we tried to have patients and caregivers enrolled in Connect Care who were currently in clinical practice and try to fit these on-demand visits in as they came up. Again, not knowing what the volumes would look like initially, we thought this would be a successful way to kick off the program. Over time, however, as patients tried to access this care, we struggled to get early and quick access to this on-demand service, and patients were waiting a little bit longer than we'd like them to as they tried to access this service. So recently, we've put a hold on really promoting this service until we would be able to staff a full-time clinician. And recently, we've just hired a full-time clinician that's going to be a virtual provider with one of her primary responsibilities to staff and be available for these on-demand services during our hours of operation. And so as this person gets hired in the next week, we will be promoting the service again very aggressively and even doing some Google ads to market and promote this service so patients are aware they can contact the PT immediately for an urgent care visit during the hours of operation and receive that care that is required. And we hope to see our numbers start to jump significantly once we have this outlined a little bit better. The third area where PT and other rehab services has an opportunity to impact healthcare is in clinical integration. And there was a recent article back in December of 2024 in the PT Journal that outlined some that gave a really great explanation of ways that we can partner with our primary care physicians. So there's two slides from this article I wanted to throw in today. The first model is the triage model, which is similar to what I've talked about and described in the spine care pathway, where patients enter through a triage or direct access through a primary care call center or online booking program and can determine whether or not they're appropriate for PT or a primary care service, and then have that early, quick access. The second slide that I wanted to share from this article is really related to the warm handoff, where this is more of a partnership between primary care and other entry-level practitioners and PT that may be co-located within a clinical office space or in adjacency where the primary care and PT providers can partner to provide a clinical integrated approach to providing care for patients. And so we've been trying to do this in a number of areas in Intermountain Health in our system. The first is clinical integration regarding in regards to our at-risk patients. In our Nevada market, we have 100% at-risk clinics where all of our Medicare Advantage patients are in these at-risk contracts. And so their intent is to keep them as healthy and well as possible and reduce the risk of serious disease. One area that we were reached out to by that market to say, hey, we have an issue with falls, and we'd like to embed a therapist within our clinic to provide fall risk screening and assessment and intervention where necessary to try to reduce the downstream costs of a patient that could fall and potentially be hospitalized. And so about a year and a half ago now, we embedded a therapist that is employed within that medical group facility. They're part of the clinical team. And if the patient comes in for their primary care annual visit, they do a fall risk assessment. If that patient is determined to have high fall risk, they are referred to our PT, and that PT takes them and does some education training and can do in-person, virtual, or even some remote therapeutic monitoring, such as recently implementation of our MedBridge pathways to help manage these patients with fall risk and try to reduce the cost of care downstream. Because of this, we're working on some future projects with these at-risk partners to see how we can embed virtual PT access for patients that may be at high risk for knee conditions such as knee OA and try to prevent downstream costs through reductions in surgery and keeping people as well as possible, right, by reducing the need for further care downstream. So we're really excited about some of these clinical integration projects with our at-risk teams so that we can try and proceed in providing appropriate care in the long term for patients by keeping them well. Another example of clinical integration is how we've been using pelvic therapists. Our pelvic therapist is part of a care team in one of our primary care sports medicines clinics that specialize in hip diagnostics. This team has been very successful in supporting patients that have pelvic issues related to hip and then feeds appropriate referrals from that clinician into their regular therapy clinic outside those hours where they're embedded in the primary sports clinic. Oftentimes what will happen in this clinic is the physician trusts this therapist and is really reliant on her expertise, that any patient that comes in for a hip issue is first triaged and screened by the PT, and then the PT communicates with the primary care sports medicine physician and partners in determining the best plan of care and determines what opportunities there are that therapists can also play a role and what resources pelvic health can provide for this hip diagnostic clinic. And currently for our pelvic therapy across the system, our primary referral into our pelvic therapists are our primary care sports medicine providers. So they've seen the value of having PTs as part of their care team. And so they've significantly increased their referral rates to our pelvic therapists because of this partnership. Our next project, and that we're moving forward with, is our women's health leadership team has come to us to say, hey, how can we embed our pelvic therapists within our OB-GYN clinics and figure out how we can provide some partnerships there to embed these therapists to provide a streamlined approach and a team approach for patients suffering from pelvic pain that come to the OB clinics. Some additional processes that we're working through and opportunities that we're seeing in the clinics and in the future is embedding some of our hand therapists in a post-operative clinic for hand surgeons. We're working through a process right now to have that happen in one of our hospitals in the system. An area that we found some significant success as well is embedding our lymphedema therapists in wound clinics and even cancer clinics, so that continuity of care can be provided regardless of where the patient hits the clinic. So they come in for wound care, they can also receive their lymphedema treatment at the same time and reduce the cost of care and also improve access to those services. We have a very robust cancer program in our Denver market where we've had some therapists embedded, both OT and PT has been embedded in 2 cancer sites at 2 of our large hospitals where they can provide lymphedema, they can provide conditioning and post-operative and even preoperative care for these patients suffering from cancer. And we're trying to scale this across the system currently to increase access to patients to cancer services from rehabilitation. And then finally, we're working to embed some speech therapists in one of our ENT clinics to see if that could be an opportunity to additionally streamline care and provide services in one location for all the care the patient needs instead of referring them back and forth between these services. So a lot of great opportunities as we look at our health system to say, how can we be partners in health with our physicians to improve the access and cost of care for patients? And then some future initiatives that we've been working through is how do we scale some of the things we've learned in the spine care pathway for all MSK navigation, and how do we get our MSK providers, our therapy services upstream as far as possible to be the early entry points for MSK conditions. And so can the entry point be a navigator that then gets patients with a knee pain or back pain or shoulder pain appropriately triaged to the right provider, which we feel like would be oftentimes a PT, OT, or speech therapist, and then refer patients that need to be seen by medical providers to those medical clinics as necessary. So hopefully we can build upon some of the momentum that we've seen with our spine navigation and expand this into our MSK navigation as well. And we have access opportunities with early access to through virtual care in these clinics as well. So we're looking for opportunities to really be that community resource for reliable information by making it easier to get to a skilled provider than it is to just Google something or ask your neighbor what they did for their knee pain when it happened to them. So looking for some very aggressive ways to be proactive in this area. And finally, I just wanted to wrap up with a few recommendations about navigating the resistance to PT and FIRST initiatives. I think anyone who's tried to use these approaches recognizes that there is resistance from many sources for PT FIRST for PT FIRST initiatives. First thing I would recognize is that I would recommend is that we acknowledge the reasons behind that resistance. Healthcare in the US has been guided for so many years by the managed care model of the gatekeeper model, which traditionally has been primary care physicians. PT FIRST initiatives challenge this paradigm, and we must acknowledge how this is seen by our physician partners. There is significant control and financial incentives that are at risk for these providers, and in many situations that must be recognized, and we must become partners instead of competitors in this market. Second thing we must do is look at physicians as our partners, and by gaining trust and demonstrating how PT can be part of the solution, not just additional cost. By doing so, we can gain momentum in being part of the solution, not part of the problem. Our spine care pathway is being successful in getting off the ground as soon as physician leadership determined it was the right thing to do. So while our rehabilitation leadership had been working and influencing for years these kind of PT First initiatives, it was really brought to light when physicians got on board and said this is the right thing to do and got buy-in at a system level by their support and partnerships. And thirdly, we need to consider what words we use when using our PT First initiative. Sometimes a PT First initiative could be construed as we're trying to go out on our own, we're trying to be too autonomous, and we're trying to work outside the system. So we may want to consider the words we use, and knowing your key stakeholders, knowing your organization and how they view physical therapy and rehabilitation services can play a great role. So we may want to consider, are the words we're using really supportive of our system, such as proactive care, value-based care, or upstream care, or is it focused solely on PT? So my recommendation is as we look at partnering with our health system, is that we use the right approach and make sure that we're looked at as partners, again, not as competitors, and working within the health system to make things better. So as I wrap up, I just want to say that physical therapists and rehab providers are certainly and will certainly continue to play a very large role in the healthcare system as cost and quality and access improvements continue to be a priority. Our services will be key in achieving healthcare viability and sustainability now and in the future. And I'm really excited to see where we go as an as a healthcare system, but also as healthcare providers in rehabilitation, because we certainly have a huge role to play, and we will continue to have opportunities in the future as we look for them and partner with our partners in not only healthcare systems, but in physicians. So with that being said, thank you for being on today. I'd love to open this up to some questions and field some discussion on what's being successful in other systems, because we all learn from each other in so many ways. So thank you for your time today. Christy, I'll turn it back to you to open it up.
Wonderful. Thanks so much, Stephen. Okay, so we have two questions that are in the Q&A box. So we'll start with those. And then as Stephen mentioned, if you would like to have your line opened up to join in easier flow of discussion, please feel free to raise your hand and I will open up your line so that you can participate. So our first question is, are you effectively using telehealth?
That is a great question. And effectively using telehealth is a great way to put it, because I don't think we're effectively using telehealth to the extent that we could be using it. We're pushing forward aggressively and using telehealth in every way we possibly can, by providing access points, by encouraging caregivers to offer the telehealth services to our patients, and by promoting it in the community. But how effective that's been, and not nearly like we expected to and considered it. To say it's successful today would be, it's coming, but it's not where we think it could be. We've got a lot of things on the plate moving forward to initiate these partnerships and provide better access. But we're not where we want to be yet, but it's coming quickly. And we're continuing to be very, very aggressive and looking for opportunities in that area.
Great. All right. Another question that we have is, how do you navigate resistance from PT colleagues who may be resistant to these models?
Yeah, that's a fantastic question. I think 5 years ago, that conversation was much different than it is today. And I'm not quite clear on what it is that's pushing our therapists to be more proactive in this area. But I think it's a combination of, we've had direct access, at least in the states that we operate in, for many, many years. We've promoted the requirement for referrals needs to go away, right? I mean, we don't have to have a referral to receive to get services. And the more we talk about that with our providers, the more they recognize that their abilities play a big role in the healthcare system and providing early access to care. And also talking about the challenges that physicians raise, right? I mean, physicians have a hard time getting patients seen quickly and have a hard time getting patients into their clinics. And so they're relying on us to say, hey, how can you help us solve our problems? And as we look at access from a perspective of, hey, we can provide early, quick access and we promote that from a clinician standpoint, from a PTOT speech standpoint. We've had a lot more buy-in, but I think sometimes the therapists think about the concerns they have and their confidence in screening patients and being able to refer somebody out appropriately. And so by having the relationship with physicians where if they have a red flag that they need to refer on to a medical provider, they have that ease of access to get those patients in. And so that partnership has also helped to reduce that resistance, because they know they've got a physician across the hall or a quick phone call away that they can call if they need to refer somebody on.
I have one for you, Stephen. We have a great group of people on here, and PT First is obviously, high on my list as a PT, but so is advocacy. And you really presented some great numbers about, proactive care, and PTs are proactive care. So if you could kind of give the group here some suggestions for what they can look at from their PT clinics whenever right now we're volleying for like that wellness visit, and we're volleying for the PT group to be, that proactive care versus that reactive care. What would your suggestions be for like advocacy or what they can do to make a difference?
Yeah, Keely, that's a great point. Where I've seen the most momentum for this is in cost savings, right? If we can demonstrate to our payers that there is cost savings related to PT First initiatives, that's going to probably drive more momentum than anything else. And the second thing is doing the same thing with our physician partners to say, physicians are really trying hard to make care accessible, make it affordable. I mean, we're all trying to do the same thing. So if we can show that we're part of the solution and not part of the problem, to say, hey, we're not going to overtreat patients, we're going to refer them when necessary, and we're not going to do a lot of things that are unnecessary, which can increase the cost of care. That goes a long way in developing trust. I think as a profession, we've got to be very cautious on saying everybody needs to see PT, because not everybody does need to see PT. Some people need to be seen quickly somewhere else, but we can play a role. And if we keep people in our clinics longer than they need to be, or don't refer them quickly enough, it puts us in a situation where we lose that trust, right? And so, and a couple examples I'll share. I mean, we have with the spine care pathway, again, we have triage, right? We have our physicians seeing them in the ED, then they get triaged by a nurse navigator, and they still hit our clinics. And sometimes they're still not appropriate for PT. We've got a couple cases recently of cauda equina syndrome that was missed, or it didn't present until they got to the PT clinic, and we were able to quickly refer them back to our navigator and get them to the spine surgeon quickly. And that's gone so far into just helping build that trust to say, hey, look, our therapists, they do screen, they do refer out when they need to. And so we're gaining that trust by every interaction in that manner. So the more we can gain that trust, the more we can really show that we're demonstrating savings and we're doing the right thing for patients, the more I think we're going to be a key player in really solving some of these healthcare problems and not being part of the problem.
Thanks, Stephen. All right, we have another question in the queue. How do the number of patients per day a therapist sees in a primary care practice compare to the therapy clinic? And is it similar or an investment of the therapist time to generate overall cost savings?
Yeah, great question, Chris. I think it varies based upon setting. So so I'll use a pelvic therapy clinic for an example, our pelvic therapist embedded in sports medicine, an example. Because of the way and I won't go into details on this, our therapist is not able to bill out of that clinic because of the way the clinic's set up. And so because of the at-risk nature of that clinic, the physicians are fine to have a therapist in that clinic and not bill for service because they're not fee for service, right? So that helps us to be an important part of the clinic without having to worry so much about how much revenue is coming in. If it was a revenue generating clinic, it would be a much different mindset, because we've got to have productivity standards and recognize that there's a need to generate significant revenue to make it cost effective. And so the at-risk clinics, it's most effective. In our clinics where we don't have the at-risk component, we still have to maintain standards of saying, hey, you've got to see a patient, every 45 minutes and bill for what you do. But we don't look at this from a productivity standard as much as we really do in our typical setting, because it's a partnership that helps us to make sure patients get the right care quickly and don't have to jump around the system to get that care. And so we look at it as a cost savings opportunity more than a revenue generating opportunity. I hope that makes sense, Chris, what I'm saying there.
He said, yes, it does. I was say, made
Great.
sense to me. And another question for you. What would you say what would you say have been like the top 3 barriers to implementing these programs? And then how did you address those?
The top 3 barriers, that's a great question.
Top
I
2?
would say the first one is getting system buy-in. I mean, if you have resistance from the system of putting a PT in a clinic, it's just not going to happen, right? I mean, they've got to see the value of having a therapy provider in the clinic. And so the way we've tried to overcome that and are working to overcome it is to really paint the picture of, we want to be partners in health. We want to lower the cost of care. And we don't want to just have the ability to do what we want to do. I know we've had a lot of physicians push back on PTs ordering imaging. That's currently part of the Practice Act in Utah, that we order imaging, but our payers and our physicians have resistance because they just see it as another expense to the patient, another expense to our payers. And so we've had to really work hard, and kudos to our leadership team that really goes to bat for rehab to get data to show that we're not part of the cost drivers, but that we're lowering the cost of care where we can. And I think the further upstream we get to say, hey, if you get them to PT first and we can demonstrate that cost savings more and more downstream, the better we're going to be, the better position we'll be to continue to be partners. So that'd be the first barrier, showing our worth and our value. The second component is insurance. I think the second barrier would be helping our clinicians to focus on doing the right thing for patients and not just hitting a number, like not just hitting their productivity metric for the day. It's getting patients quick access, getting them in the clinic immediately and making sure they get the right care, and then leveraging the tools that we have as providers to manage that care and not just work for a certain number of visits, right? I mean, I've been in scenarios in other health systems and other practices where you're completely fee for service, and so the more visits you get, the better off you are, right? And so we don't look at it from that perspective. We've got to look at this from the perspective of, how do we get patients the right care they need and not give them too much, and find that sweet spot so they get better and stay well. That demonstrates that we're being cost effective and also using our resources appropriately. And then I think the third barrier goes down to how hard it is to get into therapy, right? Are we leveraging our virtual care effectively to get people quick and easy access? Are our clinicians looking at opportunities to open up slots to get patients in quickly? And so I think the combination between, making sure we're part of the system and making sure we're getting the partnerships in place, ensuring that we're doing the right thing for patients, and making sure we have appropriate access are the 3 things that are the biggest barriers, but also can help us be most successful as we overcome them.
Fantastic. Okay, so our question queue is empty. So we invite everybody to go ahead and put your questions in that queue. If you have a question for Stephen, we still have about 6 minutes left on our time to answer any questions that you may have. Stephen, in the interim, tell us how, if you know, the bill, the Senate bill that, for elevating PT to the primary care status or level, how did you guys do that? Were you a part of that, or give us some background on that?
Yeah, I haven't been a part of that, but I know Stephen Hunter, which many of you know, has been a great advocate in working with our health plan and the APTA in Utah. I know our VP Bob McCall has been very supportive of this, and a lot of our leadership has been and working at high levels with our physician, not only our physician partners and helping them see the big picture on why we want to do this, but also helping our health plans who have said, hey, this is great and all, but do we really want to have PTs as primary care providers in our health plan? And so helping to paint that picture has been interesting. I sent as part of I was an advocate and sent an email to my state representative to say, hey, I'd love to have you support this, and here is why. And he's a physician who replied back to me, and I was able to have a conversation with him as far as why this is important and how we're helping to improve access and decrease costs of care. He was interesting because he emailed back as he goes, as a physician, it looks like to me that PTs want to be able to order colonoscopies and mammograms, and what is it you're really trying to do here? And so it was good to be able to share with him the reasons why. But the state of Utah has done a great job, and the local APTA chapter has done a great job at really engaging legislators and physicians in our community to really tell them some of the information that I shared today about why PT can be part of the solution. And we're just not looking at driving up additional costs in the system. And so I'm curious to see where it goes. The fact that it passed our committee unanimously was really surprising to me. And so I think we have some optimism that it could pass the House. But again, it's really up in the air. And so we're asking our caregivers across the system to reach out and communicate with their state legislators and their state representatives and really make a push for this so that we have options in the future and aren't limited.
Wonderful. Yeah. NARA is also watching it too.
Yeah.
This could be the start of a great trend across the United States. So we do have another question. What is your view on the future of cash-based PT services?
Oh, I don't know. That's a great question. I really don't know if I have a good answer for that. I think there's a role for cash-based services, whether it be, an independent practitioner working in the community as cash-based services, or is it things that in a health system that are not covered by an insurance plan? I think there's always going to be a role for cash-based services, and we have a lot of high deductible plans. I'm on a high deductible plan myself within my organization, and so everything I do for the first $8,000 for my family is going to be out of pocket. So I think it certainly plays a role in what we do, but I don't think I don't think that it plays an independent role. I think it's got to be part of our health system's solution in the long term. So probably a horrible answer, but I think there's got to be a role for cash pay. But what that looks like is really going to depend on how we partner with our payers and making sure that the services we provide are recognized as necessary services that can be covered, and those things that may not be covered, are we charging a reasonable price for those services so that we can provide those to our community.
Right, thank you. What do you see? What do you see in the future for value-based care? How do you see it evolving? How do you see it integrating more into what therapy is doing?
Yeah, I think value-based care, and we use the word proactive care at Intermountain because it kind of gives a different mindset to say, how do we get patients, keep patients well, right? And rehab services certainly plays a major role in keeping people well, whether it be providing education and access to services quickly. But I mean, I'll use an example. We know that in our system, about only 50% of patients that are referred to therapy actually attend. And some of those reasons they don't attend is poor access and cost of care, right? And so to be truly in a proactive care model, how do we get that 50%, those 50% of patients they can't afford or don't have access to services, the right information they need. Because some of them may just need a little bit of education and assurance that, don't lay in bed when you've got low back pain, get up and move around and stay active. And here's some things you can do quickly and easily. And in a couple of weeks, you'll be fine, right? I mean, those are the patients that we really feel like we can impact in a value-based or proactive care setting to get people that early access to the right care and information and make it affordable and accessible so that they're not waiting around for 6 months and then have a chronic pain condition that then takes so much more time, resources, and effort and significant disability to manage. So I think proactive care is really going to be leaning heavily on rehabilitation services in the future.
Wonderful. Well, we are at our time. So thank you so much, Stephen, for your wonderful insight and explanation into the PT models. And we appreciate your time with us this afternoon. And we thank everybody for joining us. As I mentioned, this recording will be available in 72 hours on the NERA website. Thank you so much and have a wonderful day.
Thanks, everyone.